So to continue the symposium, we're going to go to the talk of Jessica Hazelton, Dr. Jessica Hazelton from the Brain and Mind Institute of the University of Sydney, and previously she was in the Universidad San Andrés in Argentina. Dr. Jessica Hazelton is a cognitive neuroscience whose work combines neuroimaging with behavioral and data analysis of fMRI. And her presentation focused on cardiometabolic contributions to brain structure and function, with specific focus on frontotemporal dementia, Alzheimer, and interoception. Please accompany with applause.
Okay, let me get accustomed. Hello, everyone. My name is Dr. Jessica Hazelton. I just wanted to say thank you to the organizers of the OHBM for selecting our symposium, and as well to Vicente, Enzo, and Hernan for putting together this symposium. So, well, why is that? Oh, here we go. So first of all, I have no disclosures to report. Before we get started, I thought I might ask everyone to do some audience participation with me. So I'd like to invite everyone to close your eyes for the moment. And while your eyes are closed, I want you to take a deep breath in through your nose and out through your mouth. I want you to try and focus on your body and how it feels in this given moment. Maybe you can notice the rhythm of your breathing. Maybe you can locate your heart. And I want you to just take a moment to feel how it feels in your body right now. So I'll invite you to rejoin me in the room after that, hopefully what was a pleasant experience. So what we've just done is an interoceptive awareness kind of exercise, or what most people will be familiar with is mindfulness. And this is going to be the common thread throughout my talk, really focusing on these brain-body communications, particularly in dementia syndromes. Oh, that's out of... Oh, sorry. Okay. So frontotemporal dementia as a lesion model is particularly interesting to look at difficulties with interoception because people with frontotemporal dementia present with atrophy to this allostatic-interoceptive brain network. As you can see here, across the syndromes that are listed, behavioral variant frontotemporal dementia really present with strong interoceptive deficits. So far we know in the literature that of interoception, that interoception is really involved with emotion and social cognition. And research in healthy people has shown that this is involving these, the functional connectivity of a number of regions, but we can find convergent regions within the anterior cingulate cortex and within the insula from meta-analytic evidence. And so previously, during some of my PhD work, I looked at structural associations between interoception and emotion in frontotemporal dementia, and found these kind of overlapping brain regions that were involved in both processes in both behavioral variant of frontotemporal dementia and semantic variant of frontotemporal dementia. And here are the key regions that we're sort of seeing are these insular, anterior cingulate, orbitofrontal cortex areas, as well as the striatum and other amygdala and hippocampal regions. So the first study that I'm going to talk about is a meta-analysis that we conducted across these three sort of domains. And what we found from three separate meta-analyses from about 20,000 studies, we had 170 studies that met our inclusion criteria. So here we were looking for studies that investigated interoception, emotion, and social cognition in neurodegenerative diseases with a structural or functional MRI measurement. And so in total we had 7,032 participants with a mixture of patients and controls. So you can see here that, so So what we had was we had a lot of different tasks looking at interoception, emotion and social cognition, and we had a lot of different neuroimaging methods, both structural and functional imaging. And so what we did is a coordinate-based meta-analysis where we did a Ginger ALE meta-analysis as well as the seed-based mapping meta-analysis. And what we found across domains is that what we can see here, these were the common regions involved across all of the neurodegenerative diseases separately across each of the domains. But what I want to highlight your attention to is these convergent brain regions involved here. So what we were seeing in both all neurodegenerative diseases combined, and particularly in behavioural variant frontotemporal dementia, these common regions within this allostatic-interoceptive network were involved across the different tasks. So this is suggesting that these similar brain regions are being recruited when when people are no longer able to interpret or relate to cues from their body, and when they're interpreting social and emotional information. So the next study that I'm going to talk about is focusing on cardiovascular risk factors in dementia. So we know that cardiovascular risk factors, particularly in the midlife period, are really important predictors of later life dementia. And so things like hypertension, smoking, BMI, as well as age and sex contribute to cardiovascular risk. But so far to date, a lot of the imaging analyses has looked at hippocampal regions of interest analyses, particularly due to the implication with aging, or whole brain total grey matter volume. So what we wanted to do in this study was look at a large cohort from the Red Light Consortium. So this was from both Latin America and North America. And participants had a physiological exam as well as MRI analyses. And we had a cardiovascular risk score that's been used in the literature before, the Framingham's risk score. And this takes into account age, sex, hypertension status, as well as diabetes, systolic blood pressure, BMI, and smoking risk. And we looked at the T1 MRI and the resting state functional connectivity. And we used the AAL parcellation to look at, within this allostatic-interoceptive network, the brain regions involved at both the structural and functional level. So what we found, actually, in both FTD and Alzheimer's disease, we saw really widespread reduced structural integrity that was associated with increased cardiovascular risk. When we looked at the functional connectivity, we really saw at the seed-based level in FTD, really this reduced functional connectivity within this allostatic-interoceptive network that was associated with cardiovascular risk, whereas in Alzheimer's disease, it was a more selective connection between the orbitofrontal cortex, parahippocampus, and hippocampus. So given that age and sex are really involved in cardiovascular risk factors, or at least contribute to cardiovascular risk, we repeated our analyses in using data harmonization to compare the interaction in FTD and Alzheimer's disease to find brain regions that might be contributing more to cardiovascular risk in these disorders. And what we found is that in FTD, compared to Alzheimer's disease, we saw reduced structural integrity of the insula and the anterior cingulate cortex was associated with increased cardiovascular risk. And when we repeated our analyses using a subsampling method over 1,000 iterations in our functional analyses, what we found is that in FTD compared to AD, we saw a really strong allostatic-interoceptive network that was involved in increased cardiovascular risk. So this is leading us to believe that maybe these cardiovascular risk factors are exacerbating neurodegenerative processes within this allostatic-interoceptive network, and that this is particularly relevant in frontotemporal dementia. So the next study I'm going to talk about is looking at intrinsic neural timescales of interoception. So here, this is the theory that these lower order brain dynamics are linked to our higher order cognitive functions that we're all interested in through this spatiotemporal integration of information. And so this integration is really important into how we experience a coherent whole. And so the intrinsic neural timescales is referring to the duration of which neural activity is correlated or coherent. And this is influencing how we're processing information in the brain. And you can see here we have these length of these different timescales operating in both unimodal and transmodal regions. And the way I like to think about it is that our brain is this really cool orchestra with different parts playing at different times, but we hear the orchestra as a coherent whole. And so here, there's this model that's being proposed by Bagnez and Northoff that the common currency that really gives rise to this interoceptive and exteroceptive and cognition is this spatiotemporal brain dynamics. And this is supported through evidence of different timescales occurring within this allostatic-interoceptive network. So here we can see that the temporal segregation and integration of the information across different timescales is what we believe is giving rise to brain health, being able to integrate these signals over time. And interestingly, in some syndromes such as autism and schizophrenia, previous evidence has shown that there's sort of this disbalance between these autocorrelation windows in autism, for example, between these unimodal and transmodal brain regions. And interestingly, in schizophrenia, there's these differences in this autocorrelation window during self-referential processing, but not during at rest. So the idea here is that maybe brain diseases can be understood as a failure of this temporal segregation and integration, creating sort of a fractured or incoherent representation of what's going on. And in terms of interoception, this could be related to an inadequate management or response to the internal cues from within the body. So what we did in this study from the Red Light Consortium again, we had participants with behavioural variant frontotemporal dementia and Alzheimer's disease. Participants completed a neuropsychiatric battery, including cognitive and emotional tests. They did an interoception task where they had whole brain 128 channel EEG, and they were asked to either pay attention to their own heartbeat or pay attention to an audio recording. And again, we had T1 images here. So here we're just showing the standard pipeline for EEG processing. So after we had done the pre-processing, what we did is we calculated the autocorrelation window from each heartbeat across the brain. So this was looking at we first plotted the autocorrelation function, and then we looked at the autocorrelation window at 50%. So this is where the signal was 50% correlated with itself, but located on the heartbeat. So what we did then is spatiotemporal clustering analyses. So we did permutation testing of 5,000 permutations, and we looked at this spatiotemporal clustering to see where in the brain it was different between patients and controls. Next, we looked at how this relates to behaviour. So we looked at the significant clusters, how it was relating to cognition and social cognition, and we did voxel-based morphometry using the AAL parcellation over the 116 brain regions to see what brain regions were related to this measure of interoception. So what did we find? We found in BBFTD compared to controls, there was this delayed processing of the interoceptive signal, in these bilateral, more temporal and parietal regions. And the average of these autocorrelation score was associated with both cognitive and social cognitive performance, such that a longer autocorrelation window and a diagnosis of behavioral variant frontotemporal dementia was associated with worse performance on both cognitive and social cognitive tasks. When we looked at the neuroimaging, a longer autocorrelation window was associated with reduced grey matter integrity in the insular and anterior cingulate cortex. And when we used a more extended mask, what we found is that as well these more parietal regions were involved, such as the angular gyrus, as well as the hippocampus and the posterior cingulate. So here it's suggesting that these altered neural timescales of interoception in BVFTD may be contributing to the behavioral impairment that we see in the clinic. So some take-home messages. So hopefully you can see that some convergent brain regions appear to be involved in interoception, emotion, and social cognition, and that this is particularly relevant in behavioral variant frontotemporal dementia, which is a disease that is really characterized by really stark changes to behavior and personality, as well as responding to physiological cues from the body. So it appears that increased cardiovascular risk appears to be related to brain networks really susceptible to pathology and dementia, such as the allostatic-interoceptive brain network, and this is particularly relevant again for people with behavioral variant frontotemporal dementia. And finally, delays in this interoceptive timescales in people with BVFTD might be able to provide us a new mechanism for understanding the behavioral impairment that we see in these people. So some other sort of, not take-home messages, but more ideas for the future. So we know that in dementia, early physiological changes are occurring well before people show up to the clinic. So whether or not we can find people earlier on in the disease course or find markers of physiological changes will be really important to find people in these pre-symptomatic stages and identify people who might be suitable for drug trials. We also know that to that point, people with FTD have really earlier damage to this allostatic-interoceptive network, with changes in the insula being seen up to 15 years before people are in the clinic. And I think at the moment it's much more easy to find people who are suitable for drug trials than it is to potentially regrow their brain once the tissue has been damaged. So my open ideas and questions are whether or not we can, to this point, track trajectories of disease and identify people earlier along. Really interested in looking at whether there's a specificity between neurodegenerative disorders or not, or whether this is a common thing that's kind of occurring but just at different stages. Whether or not there's the involvement of multi-system organs. So, a lot of the research has been looked at in this area of interoception is looking at how people respond to the heart or heart function and brain function, but what else is going on in other organs of the body. And also whether or not we can find ways to intervene earlier on. So whether or not actually reducing cardiovascular risk in the midlife period will lead to better outcomes and reduce dementia risk. But wait, there's more. So interoception, I've been saying that interoception is really important in social interaction, social cognition and emotion. But what about the overlap with psychiatric disorders? So we've heard about the RDoC approach and how common symptoms across different diseases might have, that might be where we should look. So you'll have to come and see me at my poster at 2:49 to talk about the imaging results for that. So I'd like to say a big thank you to the team. I did a lot of this work during my postdoc in Argentina. So a big thanks to the team and a big thanks to the people who live with dementia who come into the clinic and participate in our research.
question? So if you have any question, I don't see any question in the app, but you can approach the microphone, please.
I think I just explained it all way too clearly, and it just makes too much sense, and we're all going to find the cure to dementia. Thank you, everyone.